Dr. Dave King, thank you for coming in today for Irregardless. And we were just talking about different things that we could talk about because you've got a lot that you've done. But being an orthopedic surgeon, who you specialize in your hip specialize?
Sports medicine, so hip, knee, and shoulder, basically.
Okay. And I was just talking to you, and I like the ideas of like roads to success, like what you've had, like moments you've had along the way. And we were talking about the concept of every human is some percentage squeamish. And I think those that aren't, I think there's some percent something else. And so I wanted to like talk to you about, were you squeamish before you went to med school? And then we want to walk into, you've got med school, you're doing cadavers, but at some point you're on your own, you got the scalpel and you got to cut somebody.
Yes, you do.
Tell me, kind of walk me through, were you squeamish?
Yeah. So that's kind of I'd said the time I was a little kid, I broke my arm when I was a little kid, and I remember having my cast on, and I said, I thought the whole process was amazing. So I said, this is what I'm going to do. Okay, I'm set. I'm going to be an orthopedic surgeon. I mean, I'm like a little kid. And my mom used to pat me on the back and say, that's nice, And then I couldn't get out of my head. So in high school, I remember I met an orthopedic surgeon and said, I would like to shadow you. Can I come see some surgeries? And he said, oh yeah, great. Come on, let's do this. Well, I passed out. I literally passed out, fell, hit my head.
Like you were in the room kind of thing?
In the operating room. And when he was doing a shoulder surgery, and it was actually the team physician for the Atlanta Braves, were in my hometown. So yeah, he made a little portal site, little stab site on the shoulder, and shoved this big metal object into the shoulder for the scope, to put the scope in, and I boom hit the ground.
Did you have like the aura or whatever that I'm gonna go?
I had the aura, I had the warm feeling, the light. I started getting dazed, but of course my ego. I was like, I'm gonna be.
I got this.
I was like, I'm gonna be an orthopedic surgeon. This can't bother me, and you can't fight it. Once you're like, going, you're gone, baby.
So you knew, like, okay, in about 4 or 5 seconds, lights out.
But somehow I thought, in my brain at the time, I thought I could win. I'm going to win this war. I can beat this, but you can't.
So there is an autonomic nervous system.
Absolutely, absolutely. But it'd be weird. I mean, I think probably everybody's had these experiences where you've had. Sometimes blood would bother me. Sometimes it wouldn't. I mean, a buddy of mine smashes his bike when we're little kids and he's bleeding everywhere, but I had to help him, and all of a sudden you're like, that's okay, and then another situation where you're watching something casually and there's a lot of blood on it and you just start feeling squeamish. So, I mean, it's natural. And even surgeons, I think, have some of that in them, but it just gets beaten out of you.
Yeah. Well, I guess
you get desensitized to it.
I put myself here.
Yeah.
I gotta do this.
But I tell you another one, the squeamish too. So I'm a full-blown finishing. Well, maybe it wasn't finishing. I was pretty close to the end of my residency. So I've thousands and thousands of surgery. Had seen the craziest stuff you can imagine: bloody, gory, everything. Saw somebody's leg get cut off by a propeller at the Lake of the Ozarks, just dangling dangling by the sciatic nerve, all those things, and didn't bother me at all. And then I remember when one of my children was being born by C-section, pulling and tugging, and she looks up and she's like, ugh, I can feel them tugging and pulling. And I had to sit down. I was like, that made me like, okay, I don't like this. Let's not talk about it.
So I remember when Sarah had a C-section, and this is the first family the first C-section that I'd ever seen. I'd never even seen a picture of it. And I was at a mutual friend of ours' 50th birthday. And
I was there.
Yeah. And I mean, it just got away from me because Sarah had her OB appointment that day. Mm-hmm. And he's like, okay, great. C-section next week. So there's a Friday night.
Yep.
And I was like, Sarah, things are probably going to change in a meaningful way in a few days. So what are your thoughts on me just getting absolutely shit-faced tonight? And she was like, do what you need to do. No, she was like, go for it, because, you're fucked in a week. Yeah. And because I've been on for 9, and then you're going to be on. And so I get home, and this is funny because they knew, I think I've told you the nurse knew you. And anyway, long night. We get home and she's like, I'm going into labor. I was, no, you're not. Like, not now. It's really a bad time for me. Anyway, end up at the hospital, walk in, the nurse goes, are you in ManShipp? And I was like, well, yes, I am. Anyway, so we get in there many hours later and Sarah starts having her C-section. I'm sort of coming back online at this point. And they cut her and they literally take all of your guts out, not mine, hers. And they like put them next to her. And I literally was like, guys, we got to stop the surgery.
No bueno.
So I understand like having to sit down during a C-section, and she has propensity, like all the anesthetic makes her nauseous. So she was actually gagging while they were doing that. And I was like, sir, you got to stop. You're making this so hard. So, but there's a part of me that was like trying to say this looks fake. I was trying to bring myself kind of down from it because it's pretty grisly.
Yeah. The belly stuff is especially grisly.
Yeah, it's like the opening scene of Saving Private Ryan. It's just like it's brutal.
Yeah, it's brutal. It's amazing though how that there's not sort of a single moment in the training that it flips. It's a process, you know. I mean, it's the max exposure does desensitize you to it over time, but you also take the emotion out of it, you know. And I remember my older sister she was a orthopedic OR nurse, you know, and she kind of counseled me on that and early on, and she said, listen, when you're in the operating room, it's a piece of meat, right? It doesn't feel pain. It's not a thing, right? They're anesthetized, and you just look at that like you're doing carpentry, and you don't even put the emotion into it. And that's pretty much what you have to do.
Okay, so when did she say that to you? Like,
that was
on the run up, like during med school type thing?
Oh yeah. That's shortly after that event in high school where I kind of passed out. How do you not have one of those moments? You're like, whoa. I've been saying for the last 10 years I'm going to be an orthopedic surgeon, and I've just passed out in the operating room. What am I going to do with my life? You know?
Do you recall specifically being like, maybe I'm not cut out for this shit?
Oh yeah. Oh, it was. I remember sleepless nights. You know, junior in high school, and I'm like, I got to get a new plan. You know, I don't really love business.
Yeah.
I couldn't be a lawyer. You know, like I may, learn to lay bricks right now because I don't have another plan.
Wow. So that was actually a real moment.
Yeah. Everybody else was like going to be a professional, athlete and something. And I was like, no, I'm going to be orthopedic surgeon.
Yeah. You had the people who were going to be professional athletes, lawyers or doctors or TBD.
Yeah. Or TBD. So yeah, it was funny. But then I went back in. I made myself go back in and kind of keep watching surgeries, and I got better at it there. So
is there any, we're going to get up into when you're doing a surgery by yourself, but you've got cadavers at med school. What's it like the first time they're rolling somebody out? Are you like, that's somebody's mom, somebody's dad? Like, does that even go through your head? Or
are you kidding me?
I would think it would.
Yeah, it's so typically I went to Emory School of Medicine in Atlanta, and you have partners, so you kind of you'll have a partner, you'll have your own cadaver, but then you'll kind of share things. Like if you find some anomaly or something anatomy-wise that's cool, you'll bring the other groups over and show them, and the professor will take you around and be like, oh, we have this there, But it's just, you nickname your cadavers.
Sir, how long are you working on a given cadaver?
My cadaver had this massive schlong and had a penile implant, so we could pump it up.
Seriously, he was like a pair of Reeboks.
It's ridiculous. Yeah, but It's amazing, but then you have a ceremony at the end, so they bring the families of these people that donated their bodies, and you actually
really?
You have kind of like a special appreciation ceremony, and there's two sides of it. You are
did you hand
very
back their
appreciative.
schlong like
no, and
wanted you to have this?
We saw.
Yeah, we can touch it another time.
I can't say. Yeah, this is. I don't know who's going to listen to this someday. But
yeah,
but it was kind of amazing there. But yeah, so it's super freaky. I mean, the craziest thing I think was dissecting the eye and the hand. Those were the two things, besides the privates, but those were the two things that you're just like, holy shit, you can't help but look at your own hand and think about this and your eye, and it's freakish, you know. It's what we were just talking before we got on this, though, about the idea of there's a reason why you can't spend too much time thinking about your death, right? And what is the meaning of all this? And that happens for the surgeons for sure, especially in orthopedics. But yeah, when you stare at your hand and you've done that dissection, you know what the pulleys are and what the flexor tendon looks like.
There's a lot of stuff.
It makes your head start spinning, and then you just have to kind of wash it out and get back to business.
I mean, we were talking about that. I had this, partner did this hand surgery, and the one surgery I've always wanted to not have is to have someone put a scalpel through my palm. And it's like, I haven't had a lot of them, but this is one I really didn't want, because that's like you're saying, that there's something about the hand, and I didn't go to med school, but like there's a lot of shit going on in there, and it'd be better if you didn't put a knife through it, but it's just the way it worked out. So how long are you working on a given cadaver? Is that like a semester long thing?
Yeah. It's like a full semester. So you'll have, you'll take essentially like a week. You'll have specifics. We're going to do the digestive system, or we're going to do the heart, we're going to do the chest cavity. So you'll have a week sort of with a purpose, and then you'll kind of have like a mini quiz, and they label people's different cadavers, and you walk around and you have to say what it is or what nerve root supplies to this muscle or something like that. So you'll do that in steps. You kind of work through the body there.
And how far into med school are you when you're doing this?
This is right away. So
away.
Anatomy is year one. Yeah. So that's one of the basic first year classes. Yeah.
And there are horror stories of that's a very difficult class. I mean, was that, or is it just everyone who's at Emory? It's like everyone's gonna get through this, and it's probably gonna be fine, kind of thing.
Yeah. Well, so it's one of those things. It's it's just straight up memorization. You know? I mean, it's just put your blinders on and
just trust them.
Just go. I mean, it's really, I found that to be very, very interesting. And then you also realize, like, this is the foundation. I mean, everything you talk about. So pathophysiology is the big term you use for essentially how systems work. Like your cardiovascular system. The heart's pumping to the arteries, and the deoxygenated veins is coming through the veins, blood. So, I mean, the anatomy, you're constantly kind of going back to that and thinking about, oh man, I held that in my hand. Oh, I know what the mitral valve looks like, and those kind of things there.
Mm-hmm.
So it's I mean, that's where you start it. I would encourage, my daughter's she's about to start a nursing program, or nurse practitioner program, but she's doing anatomy right now. It's not human anatomy, but I don't know why they don't offer that for non-med school.
Well, it's so interesting.
It's fascinating. And now there probably are. I haven't even looked online. I'm sure there's crazy, realistic, AI generated stuff that you can get into it. But I think everybody should have to take some human anatomy. I think the world should. You'd have so much more appreciation for the stuff,
Well, it is a complex system that even, I mean, I did a lot of biology stuff undergrad, so I've got some cursory understanding of the complexity and all the feedback loops and how the body. I mean, the majority of us, our body stays in balance, and it's actually wild that you think like an internal combustion engine has a lot of fucking parts. It's like it is crazy. But was there anything in anatomy that you're just surprised you about us?
Yeah, it seems very fragile.
Mm-hmm.
When you're holding the aorta, which is the largest artery essentially in your body. It's thin,
Right.
It's thin.
That's it, huh?
And then you're using your dad's garden hose you've run over so many times, and you get a big split in it, and you're like, wow. I can't believe this sucker actually holds up. I mean, it's very, very, very fragile. The nerves, the cranial nerves that come out there. You're like, this tiny little frickin' thing is is giving us all this feedback, and it's regenerating itself every night, and
What?
it blows my mind. I mean,
What do you mean?
well, your body's constantly healing itself, you know. So there's something called the myelin sheath, which covers these nerves that help. It helps the electrical signal pass down the neuron. But these things are constantly regenerating themselves. I mean, your mucosa in your mouth, I mean, it turns over daily. But when you actually open up the body and you're looking at the coronary arteries that are feeding oxygen to the heart to make it pump, they're incredibly delicate and fragile. And it's mind-boggling to me. That struck me more than anything else, you know? It's sort of like, you know, and then
like how elastic are these
so
things?
you and I loved smashing heads playing football.
You loved it.
That was our, you know, I'm like,
Feels good.
the harder you hit, the more fun it was. But you do that, and then you think, and now I've held a brain, and now I have my kid putting a helmet on, and it's like, wow, I can't believe we let our kids do this shit.
Well, I'm like right on the cusp of really thinking about that, and I think that ultimately I'm coming down on the likelihood of them playing D1, the likelihood of them playing the NFL. Right. I mean, even if they're healthy, if they're good enough, just think burnout. Like, do they even really want to do it? Yeah. Like after a while, you've had so many concussions that you're kind of like, I'm kind of done getting hit in the head.
Yeah.
But when you hear this stuff, to me, what you get out of it from a character perspective, and also it's a source of strength when you're doing stuff. And you're like, well, I've felt shittier than this before, you know? And so you're like, well, I can get through that. Yeah. And, you know, the friends and all that stuff. And then you look at the science and you're like, well, it's real. Yeah. And so where do you kind of come down, or do you vacillate?
Yeah. Well, it's funny. So, I mean, I've had to go deep dive on all the concussion stuff, and it's just an evolving field like crazy. But my ultimate take, though, is that some heads can take it and some heads can't. And we haven't figured out which ones can, which ones can't. You know, there's some that have probably had 20, 30 concussions, and they're not going to develop CTE and these other bad issues. And there's somebody that gets hit once, and it's like lights out. You know, there's a kid that went to local high school here, was a lacrosse stud, and he'd had a lot of violent contact, but he went and played college and had a headshot. And it took him out a semester, almost the entire semester it took for his brain to get back. He's now in med school, which is pretty awesome. But, you know, it's crazy. It's crazy how some brains can tolerate that stuff and some don't, you know.
And there are people some people don't even get their bell rung.
Yeah.
They
just get a headache. They might get a headache, but they don't actually get true concussion type symptoms.
I'll play with people that, like, you see them get hit, and they're like, yeah, fine. Yeah. And you're like, there's no way you're fine. Yeah. That was one of the hardest hits I've ever seen. Yeah. And I was watching on Luke Kuechly, you know, who retired from the Carolina Panthers when he was like 28. Mm-hmm. I was listening to his interview. He had never had, from his memory, a single concussion till the first concussion he got in like his 8th or 9th year in the NFL.
Isn't that fascinating? Yeah.
And I was like, you're not hitting hard enough. It's like, I don't know. Like,
that's one way to look at it.
You got to hustle, brother.
Yeah.
But is that a phenomenon where some people, like, their cranium's thicker, or like their head just doesn't, like the cerebral spinal fluid or whatever holds their brain is not as, like.
Yeah, I mean, they're looking for that kind of. Ultimately, the best would, is there some sort of screening test you can do that, you know, that says they're prone to it. But right now they're in data collection mode. They're in massive data collection mode. So. And
I've also heard, because you know, as I'm thinking through this stuff, I'm like, okay, let's say you have somebody who does get a major concussion, you know, like, who is it? Gronk and these others who've gone through like this barometric therapy, I think it was, to repair these cells. Is that a real thing?
I don't know. You know, I really don't know.
Developing science.
Yeah, I mean, right. These are what you have is you have some anecdotal type stuff that is now available to set up for long-term studies. You know, but think about doing a real scientific. So in our world, we talk about levels of evidence when you're reading a research article, right? Mm-hmm. And so the highest
like
level,
a latest and greatest sort of thing?
Well, no. The quality of how much you can rely on the outcomes of the study, you know, the conclusions of the study, you know, and what the ultimate in our world for a level 1 study, the highest, the best study, is you want a randomized, double-blind, controlled study, right? Whereas where the observer and the patient don't know which side of the study they're on.
And that's the blindness.
Yeah,
of the
everybody's
study.
blind. Yeah, the guy that's recording the results, the participant who's in there, they're all blind. But you have to have, you have to match the cohorts of patients. You have to have, similar demographics and all these kind of things. They have to be like, you have to have apples and apples in these groups. And you
an
have to be blind.
organizer that then backs away from it,
Right.
kind of thing.
Right. So yeah, you're testing a medication on somebody, right? You have a placebo and you have a medication, and you have to basically screen all these people, try to create like-minded groups, and then you have to blindly give them one or the other, and then you study the effects of it, right? And you have to make sure that you have enough patients in it. That's called the power of the study. But think about concussion, like you can't even remotely perform that, right? There's no way. There's so
Not
many.
ethically.
Well, but there's so many confounding variables. Everybody's genetics. That you how do you find like groups, and then did they take the same contact? A lot of these things are we're never gonna have these like super conclusive studies on because it's just too difficult, and you need too many participants.
And I think like testing for it it may be lethal. Like you see how they test helmets at the helmet factory where they raise like the 50-pound weight up and just drop it like a guillotine on the helmet.
Yeah. I think the bigger thing that they study, the biggest focus I think right now is preventative, right? What can we do, training the neck muscles, and what are the things that you can do to try to actually limit the numbers? I mean, you can do that study, right? You could take all Division I NCAA football programs, right? And you set up where you're basically screening everybody. We now have, pre-screening tests that they do where they're it's a cognitive test, right? And then that's how you you figure out what their baseline score is, and then if they have what you think are a concussion or concussion symptoms, then you use that test to see when they cognitively come back, right? So, but they're constantly recording how many concussions they get and all that type of thing there. So you can definitely implement, hey, we're going to implement this neck program, or we're going to change this device or the helmet, right? We're going to introduce this new helmet to all of the programs, and we're going to see, does the number of concussions come down? Changing the rules. The big thing in the NFL was changing the kickoff, right? Because the speed that they get and the violence that happens with that, So
it's insane.
So I don't think we're ever going to really truly understand the concussion,
like one of the
physiologically what's happening in the brain,
Yeah.
or why it happens to this guy, not that guy. So the focus right now is just prevention.
Isn't the kind of an underlying problem, it's be hard to deal with, is let's say you make your body stronger. It's like it would be the same issue if your car doesn't have crumple zones. Like ultimately your brain is always going to be floating effectively, right, in fluid. And so the stiffer we make the rest of it, like it's just going to transfer that much more energy into, I'm thinking out loud, but like it's going to put that much more energy into the movement of your brain, I think.
Yep.
So we need crumple zones sort of in our craniums.
Let's develop that. That'll be our next project.
I'm just saying, it's tough stuff because it's very real. And back to kind of, our world, which is, I've got a rising fifth grader.
Oh yeah.
And, he's of a body type and mentality that going out and hitting sounds like a really good time.
Oh yeah. And their genetics, if they're coming from you, they're going to be violent humans. Fast, violent humans, which is fantastic.
The good kind, hopefully.
Yeah. It's funny though. I was commenting. I was like, now that having gone through med school, held a brain, and now I'm seeing my kids. I have, I'm like, I kind of don't want them to do it, right? I don't want them to hit like that. But it's funny how how certain things in ourselves it doesn't translate. I remember we had a cadaver with bad cirrhosis of the liver, and it's like you see a healthy liver and one that had been just abused its whole life.
Right, just boozing.
And I remember just thinking, wow, that's amazing. Well, I turn 50 next month, and I'm a functioning alcoholic. It's like it didn't really stick on me.
Right, and if I heard they're doing like a pickup tackle game,
I'd go right now.
Fuck it, I don't need a helmet. I'll be good. Well, it's something that sticks. That I think of like when I watch a hockey game, and you and I used to play hockey. Like I'm looking at that headgear, that they use, and I'm like, it's probably changed since I last looked in a hockey helmet. But I'm like, come on, guys, there's got to be more we can do here.
It's unbelievable
from a helmet perspective.
Well, and the fact that they won't wear a cage. You guys, you continue to lose your teeth and shatter your jaws because you don't want to wear the cage because you're
tradition.
It's amazing, but
there's a
lot to
it.
unpack. There's a lot to unpack with that.
Well, also let's think about it from just like an ownership perspective. Like that's your investment skating around on the ice down there, and sticks fly all the time, and you're in a room effectively, right? And there are walls in that room, and so sooner or later, you're going to find the wrong side of something, and your investment is now, sitting on an operating table somewhere.
They're moving in the right direction. I mean, I think I saw the stat the other day that maybe there's only 4 or 5 guys still in the NHL that don't have a shield on their eyes, at least, right? So, but to think there are guys out there who are literally putting their sight, on jeopardy every time they step on the ice. What are there, 80 games in a season? I
can't overstate how important it is to be able to see in hockey.
Hey, man, yeah, okay, they can reconstruct your jaw and your teeth, but we don't have a fake eye, not one that actually sees yet.
Do you think it's sort of the push and pull between in hockey in particular, that violence is so inherent, like it's so important to the game, and that like the enforcer, they're thinking about, well, enforcers need to be able to kick the shit out of somebody, so we can't cover people up too much. Or is that?
I just think it's vanity.
You do.
I think it's tradition. It's tradition. Tough. You're tough as nails. Same thing happened in football. They went from leather helmets to face masks that people were making fun of them. But I think a lot of it's vanity too. There wouldn't be as much star power coolness if every guy out there had a cage on. I mean, sometimes you watch the Frozen Four college. It's the level of hockey is incredible. It's not that far off of the NHL, but the experience is different.
It is.
Not seeing their face, not recognizing who they are. You're waiting to see their jersey number to figure out who the kid is.
It has a different feel. Do you think that? I mean, we know hockey people, and do you think that NHL will ever actually migrate to a full?
I think they'll just keep making a better bubble. The clear shields. I think they'll just keep making better stuff there. But or guys
until it's like a welding mask, but it's not a cage.
It's well, the thing though is the NHL. It still self-selects. Kind of certain brains. So they may never evolve.
Well, yeah. I mean, it takes a certain person. And actually, we were at a hockey game recently. And we're sitting, close enough to be able to gauge how big these guys are. And it was mind-boggling how big these guys are getting. It used to be like when we were growing up, a 6-footer, it's kind of maybe on the taller end.
Yeah.
You had the kind of smaller, really physical guys. And 6'4" is like, that's not that big of a deal.
No, not anymore.
That's just straight up dangerous because those guys can move.
They can move.
So quickly, back to, I want to get to this idea of like the first time you did your solo flight as a surgeon. So you guys are pulling these cadavers, you're dissecting these cadavers, learning anatomy. Meanwhile, taking how many other classes, by the way? You got a full curriculum going.
Yeah. It's a job.
What do they do with the cadavers at night?
They just they're embalmed, so it's just the room's freezing, so it's a super cold room. Yeah, so they just stay on the table. You just have a bag that kind of zips up. It's pretty gnarly. They get a little funky by the end. There's no doubt.
Do they?
Yeah. Oh yeah.
Wow. You gotta keep them greased up.
I'm having a little PTSD.
Well, we can move on, which is, so they roll them away for the last time. You guys kind of have a ceremonial parting with them with the families. Do families attend that?
Yeah. It was pretty emotional. It was cool.
That is cool.
It means a lot to them. To know that their loved one was part of the process. I'm sure it's creepy too, but it's special.
Do they see them?
No.
Because it'd be like a pile of parts.
No. You're in like this nice auditorium. It's very sweet.
And is that something that's specific to Emory, or is that pretty much?
I don't know. I'm guessing there's some form of ceremony pretty much everywhere. Yeah. I can't imagine they wouldn't do that. It's probably a universal thing.
What's it like seeing that person's family member? Is it kind of? Are you just? You're so immune to this whole situation by then.
It was surreal, but it felt nice. It felt right.
Yeah, you look like your dad.
Yeah.
Yeah,
too many
gotcha.
comments. Those will be offline comments. But yeah. No, it actually, at first I thought it was going to be really weird. And then it was like, okay, this is actually kind of nice. And then you felt somewhat guilty for some of the nicknames and comments just because, but that's how you deal with something. It's so creepy. You have to break the ice and,
Did you guys ever talk about like
it.
there being a reanimation moment? Like, what if this thing just like, what this cadaver just sort of started? I mean, there's so much to freak yourselves out.
Early on, yes, but then all of a sudden, once you've done all the dissection, it's it loses its personality pretty quick. So.
And when you first have a cadaver, like when you first put your hand on that, it just must be such a moment to be like,
oh,
like when you first make contact, like
yeah, I can't even describe how awkward it is, but it's also beautiful. It's really cool.
It is cool. My mom donated to
She
SLU.
did?
Yeah. It's more, I don't know if it was for science or more that she just is like, I'm not a funeral home person and I just don't want to go into that world at all.
Yeah.
I don't know. I never asked. It's what she wanted to do. But so you leave med school and then you have a residency. You did that WashU or did you go straight to Stedman?
No, I did my WashU is where I did my residency, 5-year residency. Yeah.
And is that when you were like, for someone who didn't do a residency, what is a residency?
Yeah. So when in med school, you do 2 years of book work, basically. You take all your tests, you take your board exams, all that stuff. And then you do 2 years of what are called clinicals. So that's when you're actually, shadowing and working for the real doctors. And you'll go through internal medicine, you'll go through general surgery, you'll go through ER, those kind of things, to kind of get a flavor of everything. And they give you some responsibilities, and then they kind of give you grades based on your abilities. And it helps you to sort of figure out too what kind of path you want to go. You
had a clear vision.
I was dead set, right? But a lot of people are in there, and they're kind of like, I don't really know what side of medicine I want to go on when I'm done. So you have to do those. You graduate, and you do what's called the match. So when you want to do when you want to get your residency, it's a pretty bizarre system, right? So there's residency programs are for the specialty training, and it's internal medicine, orthopedics, general surgery, urology, all those different ones, ear, nose, and throat. So dermatology. So there's different level of competitions. So there's a certain number of residency spots, right? And obviously, the more specialized it is, the fewer the spots there are.
When you say spots, lower like United States, or you're talking like
in the United States. So you have to be awarded a residency program, and then they essentially award how many you can have. Like, for example, at WashU, they allow 5 residents there at a time. I think when I was at Emory, they were taking 4 maybe, or I don't know. And some places only need 3 residents, and some have 6 residents, right?
So they're publishing the availability. Yeah,
but you have to be accredited to do that. You have to apply for these, and it usually has to do with how many patient visits, how many surgeries do you have? Can each guy get enough or girl get enough experience with it?
Sure.
Right? But so there's a set number of residency spots in the country, right? And so when you're coming out, you're competing against all the med students that are graduating for those spots, and they're ranked. There's a number one program, right? And there's top 10 programs for this specialty, and then there's the next to 20, and it's crazy competitive, and especially tends to be the more lucrative and better lifestyle, resident or careers have the most competition. So orthopedics, dermatology, those are super super sought after ones because it's a pretty good life after you finish your training, but the match is crazy. So everybody's all the 4th year med students kind of decide what field they want to go into. Then they send out applications to the programs. If they like you, they'll interview you. And then what happens is the program ranks everybody 1 to 30 that they interviewed. And then the student ranks the programs they interviewed at
double blind
1 to 5. Right.
Okay.
And then a computer matches it up.
Really?
Mm-hmm. Yeah. So they could call it match day. They literally call it match day. So
It's nerve-wracking.
yeah, you all get together and they literally call your name out and they give you an envelope and you open it up and that's where your residency is.
Can it be empty, that envelope?
It can be empty.
Really?
You cannot get a spot. Yeah, yeah.
You can fall through.
And then there's other specialties like internal medicine where they don't actually fill all the spots. You know, there's certain programs that are so disastrous that they don't have enough people that want to go into it, you know. So it's a crazy thing, and lots of think about it.
And is that done to distribute doctors across specialties? Like you just said,
it does have some, it has a lot to do with need, right? So so they're like, I mean, we can't have everybody going.
I think
into,
it's great. You want to be a dermatologist.
You can't have everybody going to dermatology. Like that's not going to work. The system's not going to work that way. So they're definitely taking away spots and adding spots, trying to steer students into different things, you know. But if you're in the bottom third of your med school class, you can just check off all of these. You're never going to get a look at all these programs, you know, because your rank in your class is super, super important.
So what happens? Do they just know from the jump when they're doing the match process? They're like, I'm just going to go straight to whatever these.
I'm going to do family. I'm going to do family
are.
practice and just kind of. I'm just going to do family practice and I'll just look around for a job and I'll get a job. I mean, there's always going to be a job, but it might not be in what you want to do.
And could you get more than one match?
No, that's the thing is you only get one match. Yeah.
So
and then it's basically binding.
Really? Okay.
Mm-hmm. Yeah, you don't get a choice, right? So it's not like, hey, these three programs
creating options.
These three programs all ranked me in the top 5. You know, I have a spot there. You can't pick. The computer matches you.
Oh, the computer does it. So it organizes the field.
Yep.
So that you couldn't end up with options.
Correct. And they're supposed to. You're supposed to be no backdoor communication. The program's not allowed to tell you where you are in the rank, and you're not supposed to tell them if they're the top choice.
And if you come into this information, you probably keep it to yourself.
Yeah. Yes. Oh, yeah. You definitely keep that right. But like ours was wild. So my first wife, she was doing law school. She's from St. Louis, which is why I came back here. But we were in Atlanta. I was at Emory, and she was doing law school at the same time. We were both finishing at the same time. But I had planned to stay at Emory. There were definitely some winks and handshakes that I was going to stay there. I had a job set up after I finished my residency. Yeah, I knew who I was going to join and all this kind of stuff there.
Wow.
Where we were going to live, everything. The whole thing was set, and it was this. So we were just you get to kind of you can do a couple of externships when you're in your residency. You can go try out at a program, right? So you can go travel to a different place for 6 weeks and do orthopedics there, get a sense of if you like it, before you actually sign up for all that stuff.
Okay.
Or before you apply.
It seems awfully forgiving for this process.
Yeah, well, they get a chance to look at you, and the other way around. So anyways, I was set at Emory and the whole thing was done there, and then we found out that her father was diagnosed with leukemia, and it was in St. Louis, and it was just like we got to get back to St. Louis. It's a
non-option.
Yeah. So I came back and did a rotation at WashU and at SLU, and then kind of greased the skids for that. So that's why I ended up here.
Really?
And it was crazy. But
occur?
I opened my envelope. Here I'm sitting there. I've got, my wife's father's dying. Mm-hmm. She's mobile. She wants to come back to St. Louis desperately. I'm singing and dancing, pulling my my top hat. I'll do anything. I mean, if people need a hand job to let me in the program, I'm your guy. Call me.
Yeah, how many you need?
But I got to get in this place, but I'm at the mercy of the computer. I mean, it was like my palms were dripping sweat when I pulled that envelope. I was like, motherfucker, I got to get this, And so
did you get the one you wanted?
Yeah. That was my top choice. Well, yeah, I wanted to be back in St. Louis. That
worked the fuck. You worked for it.
It was a great program. It was a great training thing. But I always bitch and moan about it though, because at the time I did this. So this is 2001 to 2006, 7, something like that. The Emory was a good old boys club.
Yeah.
I mean, it was awesome. You're attending, takes you to play golf on Sunday, and his wife brings you a sweet tea on the porch. And
that's
what
I'm signing up for.
It was, the residence room, there's like a residence room. It was all dudes. You walk into the residence room, it had like a gas station of dip. Like, the thing where all the cans are stacked
logs,
up. Yeah. And then, stack of the nudie magazines everywhere.
Yeah.
I mean, it was just like the most good old boys. Everybody was friendly. WashU was coat and tie, buttoned up, dress you down, belittle you, military style. I mean, it was not a fun place. It was terrible in terms of just the collegiality. The culture was nothing of what I wanted to do. So I got it. I was so happy.
At least have one dip.
Oh my God, it was brutal. I mean, I met some great. The residents were great, and there's a couple of the guys that I trained with. I love and are friends now. But it was the environment was so much more buttoned up, professional, and I preferred the good old boys.
Well, yeah, there's
a
some
lot
comfort
easier life.
there,
Yeah,
right?
Yeah.
I mean, how are you supposed to keep up on your medical training if you don't have that?
Yeah.
With all those playboys and dip.
Yeah.
Wouldn't be possible.
But that was so getting to the kind of the point, it is very, very military. The residency thing is so in med school, everybody's telling you how smart you are. They're all patting you on the back. You're just doing a great job. You're so awesome.
Yeah.
You're amazing. You're the best. You know how special you are. Then you show up at residency in your first year and you're a maggot. I mean, it's not as abusive as the military, but it's pretty close, and they break you down and they're, you haven't slept in 2 days and they're quizzing you on some stupid article and making you feel stupid when you don't know the answer. I mean, that's kind of the mentality. But it just hardens you.
It works.
It hardens you so much. I mean, I would say though, in a good way, but also to a fault. I used to be way more warm, gentle. I'm call me about anything. I was like the go-to guy in high school for if you have an issue, call me up, whatever like that. And I just got hardened.
Get over it.
And get over it. Your phrase, everything now is kind of, and my kids, luckily I have a sense of humor. And so my kids, we all laugh about it. When I have my harder side and I tell them to get over it, they know it's out of love and, there's plenty of hugs to go around, but
timing's everything.
Yeah. But it hardens you. And then that prepares you for the day you pick up the scalpel.
Yes.
And no one else is around to bail you out. That's the day that you're like, that's where all of that comes in, and you're just like, okay, I got this.
When does that happen in this whole process? So you've got undergrad, you got 4 years of med, you've got your clinicals that are in med school, and you have a residency.
Yeah,
your residency's a 3 year thing.
5 year thing.
5 year thing.
Yeah, and so you start out just doing all the grunt work, and you might get to close an incision here or there. You're working on simple skills. Then your second, third year, based on how good you are, how good your hands are, and how smart you are, they'll start giving you a little part of the procedure. Hey, you can do this part of this, you can do that there. And then hopefully by your last 2 years, they let you do quite a bit, but you always have your boss backup. You've always got that. You always got somebody looking over your shoulder who's tweaking this, changing that. I talk about doing a hip replacement, putting the cup, the socket in, positioning that. You get it where you like it, and then they come in and they tweak it a couple of degrees, and you're close, but ultimately you've got somebody that's going to take the responsibility and bail you out. You get into something, you got a deep, bleeder, and you can't get to it, and your palm starts sweating. Well, you got somebody to come in, and you got the hand of God to come in and take care of you there.
Right.
And then your fellowship. And
that's happened to, I assume, every doctor on the planet, where you have your learning process. You're like, oh fuck.
Yeah.
And like,
oh God.
It. What was happening for one of your oh fuck moments? Like, was it a deep bleeder or was it a?
It was a deep bleeder. It was a pelvic deep bleeder. Somebody had a hip replacement that had failed. It had become loose over like 18 years, right? So I was going to go replace the socket. Well, when I got in there was all this terrible bone. The bone had kind of disintegrated, so I had to put this augment piece in to kind of restructure the bone, right? Well, when you're putting that piece in, you have to put screws and things like that, and you're working on an area where you're like, I'm not usually over here. Like, this isn't like a regular thing there, And I remember I got a branch of like the gluteal artery, which comes from the backside, and it's not easy to see in the field. You're looking through this big giant hole, and you're sitting in there, and it's kind of bleeding, and I'm like, I'll watch that. I pack it with a little pack. I'm like, maybe it'll just clot off and be fine, take it out. And now I start looking at it, and it's getting heavier
Like
and
pulling
heavier and heavier, and I'm like, ooh, okay. So, finally I get, I can put my finger behind the pelvis, and I can clamp it off basically with my finger, but I'm like, how am I going to get to that motherfucker?
Do you have to make another incision?
I basically almost had to double the size of the incision and put retractors everywhere, because that distal branch is coming off of a bigger artery, and if you just start, blindly grabbing around there, all of a sudden you hit that and open that up, and it's, game over right there. So that was the worst, probably the worst moment that I'd have. But I just, you go back to the training, you count to 10. I think I had my assistant, hold his finger on there, and I stepped back and just did a lot of breathing, said a couple of prayers, and we eventually
had a couple of six in the OR.
Eventually got a clamp on it and tied it off with a vessel loop. But that was like a oh shit moment,
Well, so
and there was no one to bail me out,
that was okay. So you're solo.
Yeah, there was a dude. There was a guy next door. There was a guy next door who was an ortho guy that kind of could have come lend me a hand, but he wasn't. It's not like he was some mastermind that was going to be able to get this bleeder. It was
like, it sounds like the position was like a real issue, and how well it's being fed.
Yeah,
it's
crazy.
That is crazy, because it's hard to train for that.
It is
because it's one thing to do it in a controlled environment where you've got your mentor,
Mm-hmm.
or what are you guys called them, right there. You can always reach over, do whatever. So we were talking about this before, and I don't know if you've done this so many times now. I don't know if you can really take yourself back, but as a non-doctor, I think about how do you get to that point of making, and it's like the first time you made an incision, you're on your own, you're like, and you just literally, those things are insanely. I've dissected a frog. Yeah. I have some sense of how sharp those things are. Yeah. It's insane how sharp, and it just opens right up. Mm-hmm. What is that like? Like, how can do you just not really notice it? You're so trained at that point, or?
Yeah, I think there's the actual making the incision. You've already done 10,000 reps, right? You've already done your 10,000 reps. So I think it's more of the big picture right there. But the craziest thing is when you're actually making an incision on someone
Yes,
that's where it really changes. And I was before we were chatting about it, but I've replaced the hip of literally the best man at my wedding, and that there's a moment where you're doing a hip replacement where when you put the socket in, it's a titanium shell that has a titanium ingrowth surface on the back that the bone grows into. So it becomes the titanium socket will essentially grow into your pelvis, right?
Okay.
But you need some stability. There's a press fit, so it's got a high coefficient of friction in it, and you wedge it in to start. But a lot of times we'll put a screw or two screws to kind of just hold it in place, just to make sure it doesn't shift or rotate. And there's a specific screw when you're putting it in that if you put it in too deep, behind it lives a very, very, very big, large artery, that feeds, and you can't see it. It's behind everything, it's behind your bladder and everything else. It's sitting in the inner portion of your pelvis. And, it's the number one, it's on every test. Everybody knows where it is. There's safe zones to put the screws in, but there's always sort of that
chance.
Yeah.
Chance.
It's you hate to hear it as the public, but when you're doing it on somebody that you don't really know and you've done it so many times, you're always using your best judgment. You do it, and you don't think twice about it, But doing it on my best friend, and we were doing it.
I know this
we
dude's kids.
were doing it in an outpatient facility, right? So not in a hospital, because he was young and super healthy and was going to go home the same day, kind of thing. Mm-hmm. Yeah, and that was a moment I remember they calling for the drill and just being like, "Oh fuck."
You had like the moment of like,
Yeah, that's like, this is it was one of the only times in recent times that I can think about actually kind of having nerves. You just get so deconditioned to the whole thing. But that first day is crazy. That first step, the first scope you do, and the first time you get yourself into some sort of little bit of trouble, that's when you're like, oh man, this is real.
Is human anatomy consistent enough that, like, you can count on the mapping of the human body? In general, it's going to be really unlikely that if you put it in the same place, that something's going to be there that you weren't expecting.
So I would say in orthopedics, yeah, I would say yes. I think in some other stuff, the abdominal cavity, it's a big guessing game. I mean, yes, there's patterns. You know where the ascending colon and descending colon should live, but there's all sorts of anomalies. So you have to be prepared for anomalies.
So what is in this slightly? And I'm going to wrap us up because I don't. What time is it? I don't even know. It's 2:17.
Yeah.
But ligaments, sports. What's the latest and greatest on those repairs? That's the repair that I remember growing up. They blew out his ACL.
Yeah,
lineman or something. He blew out his ACL, and it's like a year.
Yeah, we could do a whole nother podcast on ACL. That's the craziest thing ever because it morphs into so many things. So
ACL's on the back. Is that on the one of the
cross?
crosses?
So yeah. So it crosses in the middle of your knee, and so the ACL sits in front of the PCL.
Okay.
And it basically prevents the tibia, the lower bone, from coming forward and rotating against the femur, right? So it's a very specific motion that it blocks.
And that would be which direction hit breaks.
So it's more of a plant and buckle kind of thing.
Okay.
Yeah. So it's a rotational torsion that's going to cause that to tear there. But to your point, not much has changed really, honestly. We're still having to, if you're a young athlete, you still have to harvest their own tissue. So you're taking their patellar tendon, their hamstrings, or part of their quad tendon is kind of a newer design.
Like slicing off.
Yeah, you have to take a section of it off to reconstruct it. You can't repair the ligament. When it tears, it shreds like the end of a mop kind of thing. So you can't put it back. Yeah, you got to use new tissue. At our age,
when it tears, is it coming off the bone, or is it like in the middle, or it could be anywhere?
Two things. Yeah, typically it tears from the femur, the top bone. That's the most common. But then it can pop off the bottom or tear in the middle, right? But all of them, once the ligament tears, it's gone. You got to put a new one in.
So you cut out the old one.
Yeah, take it, throw in the trash. Yep. And then you either take their own tissue, or once you hit your 30s, you can start using cadaver tissue, right? So you can use
because we're basically slowly dying at that point.
Exactly. Well, for some reason we just get stiffer, so the re-tear rates are lower when you get into your 30s, even if you play sports, high-level sports. So it's crazy the data on that. But what's the future for the ACL stuff, right? We know how to position it. We know the techniques for all of it is there's not a lot of rocket science. But what the coolest thing that I think is going to come down the line is going to be, how do we make that graft incorporate and become stronger? And so we're always looking at things like, can we wrap it in some sort of thing that has different growth factors that signal it to grow in faster,
meaning like attaching to the bone?
Yeah, to attach to the bone, and then essentially it grows a new kind of nerve and blood supply to it.
Currently,
right?
it does.
It does. Yeah. So they've done. So the cells that are in the tissue, even if you take your own patellar tendon, right,
mm-hmm.
and you put it in, there are cells in that tendon that at day one, those cells die, and then they get repopulated from the femur, right? Okay, so cells actually, yeah. So it basically kind of grows this new blood supply and nerve supply. But how do we make that go faster? That's the whole thing, is how do we speed this whole thing up? Why is this, a lot of the college female athletes that play on turf, most schools have gone to 9 months. It used to be 6 months you can play. Now they've taken that out to 9 months because the re-tear rates are so high, So our whole thing is, how are we going to make those incorporate faster? How do we make them stronger? There's all sorts of scientific stuff.
Is there such a thing as say you take somebody's, what's it called, autologous? Is that what it is?
Autologous is your own, yeah.
When you donate to yourself.
Yep.
Is there such a thing as it not taking? Like it doesn't innervate, or it doesn't?
Yeah, not so much anymore. I mean, I think we've got the techniques down so that they incorporate well. It's just, you tore the one God gave you. You're going to go back and play a sport. How do you think you're going to be better than you were before? So that the graft is still at risk of tearing. Yeah.
Okay, because I remember back in high school, maybe it's just the good news that people like to offset the bad news with. Oh, you're going to come. I think it'd be stronger.
Lie, total lie.
It is a lie.
Yeah, it's a.
Okay, now that makes sense.
Yeah, it's a total lie, and it's just meant to give you some confidence. Yeah, because I have it all the time. You do it, and you're a young athlete, and mom's just looking at you. Are you sure they're ready to go back? Are you sure they're ready to go back? And now the physical therapists have helped us a ton. They develop all these tests, to try to make you feel good about it. The landing angle of your knee when you jump, and hop tests and all. They're doing everything they can to try to see physically, are you doing the right things that are going to put you at the least amount of risk of re-tearing it. But ultimately, I have this stud lacrosse player, recently. He's clearly like high level college material.
Mm-hmm.
Tore his ACL, unfortunately, his sophomore year.
Playing lacrosse.
Yeah,
Okay.
playing lacrosse. Classic, pivoted, was, making a move, and it just buckled and blew it out. It was just bad luck, right?
Is ACL the most common tear that it's in those types of sports?
From a ligament standpoint, yeah. Okay. Well, it's the one I guess probably the most common is the MCL, but it heals itself, so nobody cares about it, right?
Okay.
But the ones that actually you have lost time with the most is going to be the ACL. But
this
kid, we reconstruct his ACL using bone patellar tendon bone, which is a miserable recovery, but it's in my world it's the most it's the best to hold up for abuse, right? And the kid wants to play as long as he can play. Does everything right. I mean, this kid is, he is.
It's just such bad
diligent, everything like that. Gets back, has his brace on, is in practice, and is doing a drill, kind of showing some of the younger guys what to do, and some younger, inexperienced kid just loses his footing, trips, and falls, and just lands so perfectly that he buckles his knee and blows the thing out again. Yeah. Same ligament. Same one, yeah. And they said it was just like the way this kid fell. He even had a brace on, but the way this kid fell, this kid was just like nothing was going to save.
Did he have like a Don Joy style brace on, like the heavy hinged stuff?
Yeah. That's actually what the Don Joy, you brought that up. So total tangent, but here's one of my favorite stories. So Don Joy, their biggest competitor is Breg.
Mm-hmm.
Don Joy was the name of Donna and Joy, were Greg and Brad's first wives that divorced them. They named the company after these two. And then so they sat out their non-compete, and then Brad and Greg started Breg, and now they compete against each other.
Amazing.
I believe that's true. If you
are they still
that, but even if it's not true,
it is now.
It's the greatest story of all time.
It doesn't matter anymore.
The number one competitor is Breg. It just makes me die laughing.
Are they still like the only ones? Breg and Don Joy.
There's a few other ones, but the problem, that business is hard because the reimbursement rates from insurance are so low that the margins are so terrible that no company really wants to get in the game anymore. There's no money in it. So those two will be there for forever. Sorry.
So
that was my tangent.
No, I love this because this is all very interesting. Like we don't know, we hear about this, and all we are, you guys are kind of, doctors are a little bit like athletes, a little bit, where it's easy for us to sit here and say, boo this, or the doctor did this, the doctor did that, and I love hearing this because it's a great reminder of this is such a science, and with all the technology we have around us, and we're donating to ourselves a little sliver of a patellar tendon, and it's great to get a little bit of insight into how much science is actually happening here and how much is still being discovered. Like CTE, brains have been around as long as we have, and we still have so much to learn. So it's not a tangent. I think it's all really interesting stuff. But I did cut you off on the future. So you're hoping that you're going to have maybe a ligament repair that'll accelerate the innervation and the getting a circulatory, like a vein and stuff going through it.
Really. Well, it's really how can we signal the cells around there to speed up the process? How can we manipulate the healing process to speed it up? That's what we're looking for, And is that part of that stem cell injection world, sort of? Yeah, correct. Regenerative medicine is really the world they talk about. But so stem cells and other thing called PRP, platelet-rich plasma, which is your platelets are one of the three main cells in your blood. They have all the growth factors and everything. So platelets, if you cut your skin, the platelets aggregate together and clot. Okay. And as they clot, they release all these growth factors, which drive the healing response, right? Okay. So platelet-rich plasma, the idea is that you take your blood, you spin it down in a centrifuge and separate the platelets, concentrate them, and then you inject them into some sort of tissue to try to help them regenerate faster. Okay. Right? Tennis elbow is a classic. So your tennis elbow, the PRP injections healing tennis elbow is about as good as surgery. It's a really good option. Yeah. The stem cell thing is interesting, right? So stem cell injections have been shown, especially in joints. They have a lot of good properties. They block these nasty enzymes that cause inflammation. They can help the environment of it, but they're not really growing they're not really regenerating tissue at this point. And the reason
So it's not the sci-fi stuff.
Everybody thinks that it happens, right? So you have a cartilage defect in your knee, and somebody wants to harvest stem cells from your pelvis and inject them into there. The steps that it has to go, that stem cell has to be signaled along all these different pathways to make a cartilage cell. Then it has to adhere to the defect and solidify itself in there. The idea of just being able to blast this into your knee and it's magically going to do that is an absolute joke. Like, it doesn't, if you have any
doesn't an undifferentiated cell need other undifferentiated cells?
Well, yeah, and need other cells, which is not that hard. You can concentrate a ton of cells, but you have to figure out how to signal that to become that. So it's regenerative medicine is here to stay, but there's a lot of things that have to happen before it becomes, before we get rid of joint replacements, we need to have a lot of other science in there. But AI is going to take this
so
freaking far. The science side of it, think about just cancer, right? Mm-hmm. You're going to have very few oncology doctors in the end, because they can sequence your genome. They can have massive databases that look at, we found this cancer with these markers in this individual with these genetic characteristics. We did this regimen of radiation, whatever meds, and this was our healing rate without recurrence. You're going to be able to compute that data points, and you may have a person in Thailand, in South Africa, and Venezuela who had a similar pattern, and this regimen of things healed this cancer. I mean, it's going to be crazy what it can do for that.
And what is, something like, we think of orthopedics, maybe it's a little bit like carpentry, where you got your screws out and stuff, and you've got your drills like you're talking about. Are there implications for, it doesn't seem like AI is going to be able to cut someone open and put a screw in their socket.
What it's going to do, so what it's going to do, the algorithms right now are basically being built to feed the robot.
Okay.
Yeah. So we're using AI to create the brain to perform for the robot. We're already using it in basically when you put take a knee replacement. Right?
Okay.
So the knee replacement, how you cut the bone, the angles, all these kind of things are going to affect how well it functions and how long it lasts. So AI in the robot has already helped us, tremendously in that sense.
How do you calculate
that's going to get better, but you're eventually going to it's eventually going to do well. It's measurement. You're using reference points and guides, and it's very visual.
Because you're cutting like the top off, right?
Right.
And the femur and the shins.
Correct. And you want to make that perfectly perpendicular to the tibia bone, right? So you're using reference guides. You can use either one goes down the bone or external, and it's a lot of visual and it's tweaking and it's an art right now.
Never even thought about this.
There's plenty of science and tell you where you want to put it, but it's an art once you get into the surgery. Well, that's taking a lot of the
because you could theoretically end up with one if they did double knee replacement. Like one ends up being one leg's knock-kneed and one's not.
It's trust me, I've seen everything.
Can you see it out on the street? Like,
oh yeah,
you can.
Yeah,
that guy had a knee surgery. It didn't go well.
Yeah, for sure.
Wow.
So, but the AI will help that. But it ultimately to feed the robot to do the bulk of the surgeries. Yeah.
And are these big? I'm thinking robots. I'm thinking like the Da Vinci or something like that.
Yeah. And Da Vinci right now is a lot of it is you're doing macro movements over here, and the robot is doing micro movements. Like that's what's right now. Eventually, though, the robot's just going to do its thing.
Like I'm thinking a car manufacturer.
Mm-hmm. Yeah.
With all the assembly line and stuff.
Yeah.
So is the Da Vinci, the one now, is that still powered by a human though? Like you're turning knobs or whatever?
Correct.
So you think that link is breaking? Like the robot's just you're gonna program like a CNC table, for metals or something, and it's just gonna go.
Yep. And somebody will be kind of overseeing it.
They're with a shotgun over the robot.
Think about the brain stuff. Going into isolate a tumor. Think about it. If you could take an MRI, right, and you can feed it into the brain, it knows exactly, from a stereotactic standpoint, it knows exactly where it's going. And it's incredible the precision that's going to have.
Well, I guess at that point, if it gets that precise, it's like, can we just keep the head still enough? So the destination is right where that robot expects it to be.
Yeah.
Because now they use the halo thing, don't they? Like,
Yeah.
like basically pulling your head into like a toilet seat.
Yes, they do.
Kind of thing. So the repairs, and then the UCL. I told you I've been on the Trevor Bauer bender, and he's been talking about. And you've been around sports. I know that you've been with some pro teams, and you can comment on that if you want. But you've been around the sports. And do you think that there are mechanical true preventions to this sort of stuff, or is there just you only get you only got 50,000 pitches in that arm, and that's
So there's definitely some anatomic things. I mean, some guys are the way they're structurally built, and then their mechanics are just going to keep them away from that. Some guys side armors. Guy that's with sidearm, it doesn't put the same force on the UCL ligament to rupture it. But the crazy stat, though, this isn't really answering your question, but the crazy stat, though, is when you throw when a major leaguer throws a pitch, the physiologic force, that's the torque that's created, should rupture the UCL every pitch.
bullshit.
Yep, throwing a fastball. It should blow out. If you actually just take the tension, it should blow out every time.
What's going on there?
That's it. It's kind of like we don't know. We don't know why. But clearly, guys, certain mechanics are going to put that at less of a risk. But the volume, it's a volume game now. That thing just wears out. Here's the craziest thing.
Yeah.
Back in the day, not that long ago, 15, 20 years ago, if you'd had a Tommy John surgery because you blew out your UCL, it was a red flag. When I helped with the Cardinals, one of the team physicians for several years. We'd do exams on the minor leaguers, and you'd look at, or a kid that's getting traded. We do a medical. What's they got? They had a meniscus tear. They've had this. They get stress fractures in their back. Should we take this guy, or is it a liability? Right. And 15 years ago, 10 years ago, if they'd had a Tommy John, that was a huge mark against them. We're like, yeah, this guy's gotten borrowed time. Now, it's like, oh, you already had your Tommy John? Cool, great, we're good. Got that out of the way.
Got it out of the way.
That's
nuts.
It's nuts.
Now, is the UCL
They're
different?
Like, what? I was like, the kid had one in high school. Yeah, that's fine. Yeah.
Can the UCL repair strong? Like we were talking about the ACL. I know everything's different everywhere, but can you come back as strong with the UCL repair?
So my theory is that the UCL reconstruction is never as tight as the original, and there's play in it, but they don't have pain with it. It's kind of holding it together, but it's not doing a great job. And what happens is when you don't have a UCL and you keep throwing, you're creating arthritis essentially on the other side of the joint, but that's not going to kick in until you're down the road.
So your arm's not just like floppy.
No, it just has a little extra play in it. It just has a little extra play.
Could you theoretically pitch through that?
Yeah. Usually people
get trashing your elbow.
Correct. Yeah, you're going to have long-term consequences by having its posterior rotary instability. It just causes this instability that is not going to cause you necessarily a problem then. It's going to be something that bites you in the ass down the road.
Interesting.
Yeah.
So
my theory is that they just, unlike the ACL, which we can get tight like a guitar string, I think the UCL starts that way and then it just kind of loosens up. And so the guys, it's good enough kind of thing, but they don't re-tear them and it doesn't hurt.
So there's a low re-tear. It's a lower incidence.
Lower re-tear rate, but I don't necessarily think it's doing its full job. I think it's doing 50% of the job, which is good enough.
And do people typically hit? And I don't know. I know you don't know all the stats, but based on what you know, do not just pitchers, but people who use their arms to throw, like shortstops or whatever it may be, do they generally hit velocity again, or is there like they go down 2 miles an hour? Or
I haven't seen those numbers. I don't know. I mean, clearly they get back to be effective. Otherwise, that would be a red mark. I mean, if they never, guys come back and throw just as hard.
And for people who are listening, I remember so we all say Tommy John's, like pancake or something. So tell us how you're actually repairing it, because someone told me how it was repaired, and that like with the wrist thing, and that some people have two, some have one, and what happens when you have one?
Well, so think about the inside part of your elbow, right? So your funny bone. Think about your funny bone, right? So that the ligament lives right in that zone. Okay. When you tear it, just like the ACL, it rips apart. Occasionally you can stitch a partial tear down, but for the most part, when it rips, it's gone. You got to put a new one in. So the graft they usually use is called the palmaris tendon, which is in your wrist, but it's kind of like a useless. We don't know why we have it. It's sort of like your appendix. Like maybe it was important.
That's like this guy, right?
Yeah, if you pinch your finger and your thumb together and bring your wrist up, if you have one, so you either some people just don't have one.
Literally, like don't have.
Yep,
they've
like evolved out of it, right? So certain people don't have a palmaris, but it doesn't have any real function. So harvesting
it doesn't help us pull our hand out.
No, they don't really know why we still have it. They think it's some evolutionary thing that's still hanging around
Some
that
bullshit.
doesn't mean anything. But
Yeah.
but if you have one, they'll take that graft, or sometimes you'll have it on one side, not the other, so they'll take it. I forget what else they use. I don't really do that surgery. My partner does.
Yeah, I understand. But like, so they yank. Well, they like. How long is this? Is this going
No,
up to my
they,
elbow?
They actually, yeah. Well, no, because it's muscle. It's muscle in your forearm, and it turns into a tendon. But the way they harvest it's pretty cool. They just make these tiny little nicks. They don't open the whole thing up. They make these little nicks, and they have a little device that loops around it, and you slide it under the skin, and it shears it off. It's pretty cool.
Cool. Yeah.
The worst story though is some super well-known guy who's taking care of a professional pitcher went to go harvest. They didn't have a palmaris, and he harvested the median nerve.
Is that power the whole hand thing? Like touch?
Powers your thumb.
Is it motor or sensory?
It's motor and sensory. But it killed your pinch, all that kind of stuff there. Yeah, that was a bad one.
And his throwing arm.
That was a bad one.
That's like an oh shit moment because he probably knew it the moment he done it.
Call your med mal insurance and just tell them to give them the whole policy in your house.
So and I'm gonna wrap this up. But once they get this thing out, is that like when I'm feeling this? Is that what a ligament feels like?
Yeah, that's it. Sorry, that's the tendon. Yeah. So you're using a tendon to recreate a ligament. So ligaments connect bone to bone. Tendon connects muscle to bone.
And do they have the same sort of tensile properties? Like,
well, different ones have. No. The problem is that so we'd rather use a ligament because they tend to be stiffer and have less. They creep and all these other things that happen there. So the tendons aren't as good, but the palmaris does a decent job.
It does, but it can handle. It's ultimately it may have more stretch, flex, or whatever, but it can hold the force. Ultimately.
It can, but that's my whole point on why I think it actually stretches out a little bit because I don't. Yeah. Because if you put that sucker on tension and then just start hurling baseballs again, it's gonna loosen up. Tendons aren't that strong, right?
They aren't, comparatively speaking.
Compared to a ligament, yeah.
So ligament
the native ligament
is it's weird because can you like turn a ligament like that?
Yeah, and different ligaments.
But you can't pull them.
Correct. Yes, that's a great way to think about it. Yeah, you can twist it, like in a circular motion, but you can't pull lengthwise. And
do you think there'll ever be a time when somebody can think along the lines of like, okay, I'm gonna freeze an egg, or is it possible? Do you think in your wildest dreams that athletes can somehow have spare parts made from themselves somewhere?
Of course they will.
You think that's like?
Yeah.
I mean, how close is that? Just a crazy. I know you guys think about these things, but how far away is that?
You're telling me you don't think in some Chinese lab somewhere they might be taking their best athletes and growing
more of them?
Yeah.
And you think it's just a full clone and like, sorry, I got bad news. You're the spare part container.
I'm kidding. No, I think they'll clone different body parts. Yeah.
Cloning a real thing.
Yeah. I think they're already doing some decent work on that. There's a lot of data on that. We don't hear about it much because I think there's kind of the ethical dilemma. So I think that doesn't hit the papers very often. People want to keep that very close to the vest.
Yeah, I can't even. My head's about to explode just thinking about the implications of that. But redundancy is always good.
I mean, just think about how killer that would be. Is if you had a lot of people have liver problems, liver cirrhosis, that not necessarily because they're alcoholics like me, but I mean, just think about being able to just regrow somebody's liver and transplant their own genetic makeup. It'd be amazing.
You reach a certain age where it'd actually be easier just to take the brain out and put it in a new body. Like a full upgrade.
Yeah, nothing's going to surprise me. I mean, put yourself. You're in 1855.
Yeah.
Think about what we're doing today. True. It's just like you can't even fathom some of the stuff.
That would have been a horrible time to get fucked up by something.
Awful.
I mean, they're like anesthetic.
Snap your femur. Oh shit. Yeah.
What do they do? They just cut it. That you're done. Yeah. They just cut the leg off.
Just go to shock. You create the pain until they pass out.
Okay.
Yeah.
That's a game.
Mm-hmm.
All right, King, I got to wrap this up, man.
Yeah,
Thanks
buddy.
so much for coming in.
This was
This
fun.
has been really fun.
I had no idea where this was going. I don't think either of us did, but this is cool.
Well, no, you just kind of follow your nose, right? And you're such an interesting guy. Like it's not gonna take long.
I appreciate you having me.
All right,
This
man.
is great.
Talk
Thanks,
to you.
buddy.